In this video, we're going to go through some of the viewer questions from the previous video that we did, going through why patients with COVID-19 have low blood oxygen levels, i.e. were hypoxic. And we've got some really great questions, so we'll go through some of those in this one. A really insightful question we got was about cytokine storms. This is essentially where the body has massive inflammatory response to something, and those inflammatory mediators then cause greater and greater activation of the immune system, with white cells then infiltrating multiple tissues and causing damage. Certainly in COVID-19, one of the things that are causing a significant amount of disease is the cytokine storm itself. It probably explains why patients are developing the infection and getting the virus probably about 5 to 14 days before they actually exhibit symptoms of being unwell. This tends to indicate that maybe the virus itself is causing a secondary immune response, and it's that immune response that then causes damage to the lungs and other organs. So this has been seen a little bit in intensive care, where we've measured things like interleukin 6 and interleukin 1, so IL-6 and IL-1, which are indicators of the level of inflammation within the body. And certainly these are very high, and in those patients who become critically unwell and need ventilation, they certainly become very, very high. So it's really interesting to think about the treatments to try and mitigate this immune response and this so-called cytokine storm. So there have been a huge number of different drugs that have been looked at. And in routine management now, for a lot of patients, we're using steroids. Now, these steroids are effectively used to try and modulate the immune response. We don't have any robust data yet in clinical trials to tell us how useful this would be. However, we're seeing a lot of the consequences of lots of hyperinflammation, with scarring to the lungs, to the heart and to the kidneys. And as such, a lot of doctors have started using steroids early on in the disease to try and prevent this chronic damage to lungs and to other organs. There are loads of really interesting trials that are currently being done by the NHS and around the world that are looking into immunomodulatory drugs to try and reduce this cytokine storm and thereby hopefully reduce the immune-mediated damage to different tissues. Some of these drug trials are using steroids like methylprednisolone at very high doses, and also using different immunomodulatory medications, something called intravenous immunoglobulins or IVIG, to mitigate the immune response. And also looking at drugs such as rituximab and other monoclonal antibody drugs, which specifically bind onto certain cytokines and dampen them down, such as IL-6 and IL-1. As it stands, we don't have a particular treatment protocol, and lots of different things are being looked at. But the honest truth is we just don't know what works and what doesn't in this disease, just because it's so new. This is sort of the million-dollar question. Do patients have better outcomes if they're admitted earlier to intensive care? The problem with medicine in general, and something that's really worth trying to get your head around, is everything that we do has pros and cons. For any benefit we get, there are certain risks. Now, within this question, if I take this to mean, should we be ventilating patients earlier? So should we put them to sleep with a general anaesthetic and then put a tube down into their lungs to take over their breathing? Well, we've seen pretty good evidence over the last 20 to 30 years that ventilating a patient causes more damage to the lungs. That's because we're forcing air in and we're forcing air out. And by doing that, we can cause damage to the small air sacs, the alveoli. So intubation is never a good thing. However, sometimes we have to do it to try and maximize the amount of oxygen that gets into the bloodstream. As such, if it's about intubation, there really is a question about whether we should be intubating people early or late. And certainly the more evidence that's coming out tends to indicate we should try and stave off intubating these patients for as long as possible. But of course, in some patients, their lungs are so bad, the only thing that'll keep them alive is putting them on a mechanical ventilator. This is interesting because it's in contrast to what was originally planned, which was to try and put people on ventilators very early on, partly to try and reduce the spread of the virus as well. But like we say, with intensive care, if you've got someone on intensive care, even if they're not on a ventilator, the risk of them having procedures done to them, like having special lines put in and being given special medications, increases. And all of these lines run the risk of getting infected, and so you can get secondary infections being in intensive care. And because we use some pretty strong antibiotics in intensive care, often people can get multi-resistant infections, which can then be very difficult to clear. Moving on from that, another interesting question is whether patients develop secondary bacterial infections. And the honest truth is yes. This is maybe not related to COVID itself, but certainly if you've got a severe infection and you're critically unwell, you become immunosuppressed, and so your ability to fight other infections becomes a little less. Most of these patients also, because they're so sick and we don't want to miss a bacterial infection, we sometimes give them antibiotics empirically, i.e. just because we just don't want to miss a bacterial infection, because we know that if we delay giving antibiotics, even by a couple of hours, the risk of that patient dying increases significantly. So any patient who comes to a hospital is going to be at a slightly higher risk of bacterial infections. And then, if we put them on a ventilator, their risk of developing pneumonia increases significantly, and about 20% of patients develop a pneumonia within the first 3 to 5 days of being intubated. And the reason for that is that we get rid of all of those protective mechanisms that have evolved over years, with air moving through the nose and the mouth and being filtered out, because the air gets forced directly into the lungs through a tube. Also, because we're giving those antibiotics, the risk of them developing multi-resistant bacterial infections increases as well. Interestingly, in the COVID-19 group of patients in critical care, we're seeing a large number of patients developing fungal infections. Now, that might be partly because we're giving antibiotics, and the antibiotics are killing off the normal bacteria that would sit in the lungs and therefore prevent fungi from proliferating. But also, because we're giving immunosuppressive drugs like steroids, again, it might allow those fungal infections to proliferate. So certainly we're seeing that, and it's becoming more and more of a problem. There is a lot of work looking at the multisystem effects of COVID-19, and certainly we are seeing that other organs are being infected and also affected. In fact, about 20%, so 1 in 5 patients coming to intensive care, need support of their kidneys. There's a variety of reasons why this could be, and it may partly be related to the virus itself attacking these cells, but it may also be related to the blood clots that can form inside the capillaries of multiple different organs. In addition to the kidneys, we're also seeing problems with the heart and the so-called myocarditis, inflammation of the heart muscle occurring. And also, interestingly, there's some theories about it affecting the brain as well, and this phenomenon of COVID-related delirium or confusion becoming more and more significant a problem. So it's likely that coronavirus itself is affecting multiple different organs, and in future videos we'll go through some of the theories as to how it affects different things like the kidneys and the brain. This is the million-dollar question: current treatments for COVID-19. And the honest truth is we don't have any treatments at the moment. It's way too early on in the disease process for us to really know what will work and what doesn't work. And this is where robust clinical trials have to be the thing that gives us the answer. You'll hear people talking about things like hydroxychloroquine, methylprednisolone, remdesivir as an antiviral. And the honest truth is we just don't know whether any of those things work, and if they do work, when the right time to give them is. Let's take, for example, remdesivir, a drug that you may have heard of as an antiviral medication that can destroy the virus. Well, that may in itself be great, but if the problem isn't actually the virus, but the immune response to the virus, when they come to intensive care and they're critically unwell, giving them an antiviral probably isn't going to help, because what we're actually trying to do is minimize the damage from the inflammation. So even if we've got a drug that's great against the virus, we have to give it at the right time. So there are lots of questions here. In terms of the current treatment on intensive care for COVID-19 patients, it's really just supportive therapy. It's supporting the lungs, supporting the kidneys, supporting the heart, and keeping people alive and allowing the body to fight off the virus and hopefully regain some level of function. And then hoping that the damage that's caused by us ventilating them and the damage from the inflammation from the virus isn't too great that it causes long-term significant damage to different organs. So the question of whether the treatments that we're giving in COVID-19, whether they're used for other pneumonias, the answer is yes and no. Yes, in the sense that in critical care, all we're doing is trying to support each organ and waiting for the treatment itself to work. In this case, the treatment being your own immune system fighting the virus. Now, in other viral infections, there are specific antivirals. For example, herpes simplex virus can affect the lungs, and there is a specific drug such as acyclovir which we can use to try and kill off the virus. And it works very effectively as an antiviral. But most other pneumonias are bacterial, and those we often have effective antibiotics which we can give. In this case, because it's a viral infection, those antibiotics will not work. A question that was asked really early on in COVID-19 disease was why certain patients were at higher risk of dying. So we were seeing people with diabetes and high blood pressure dying at higher rates than those that were otherwise fit and healthy. Similarly, we're starting to see people of certain ethnic backgrounds at higher risk of dying as well. And the answer to this is still not known. There are a lot of theories out there, but there's going to be a lot more research in order to know exactly what the cause is. Just by way of example, some of the reasons that people are saying are, for example, for hypertension, so high blood pressure. These patients express more of a receptor called ACE2. Now we know that the ACE2 receptor is what the virus binds to in cells and then makes its way inside the cell to then replicate itself and thereby damage the cells themselves. So it stands to reason that if you've got more of these receptors, then more of the virus is going to get into the cells and more of it is then going to replicate within the cells and cause more damage. This could also be true for different ethnicities that may express more of this receptor than others. But as we say, we're still really early on in the disease, so we need to do more research to work out the exact answer to it, but it is exactly the right sort of question to be asking. So I hope that gives some insight into some of the questions that you've given, and they're really useful questions and exactly the questions that we are asking as researchers in intensive care and in medicine in general. If you've got any other questions, please leave them in the comments section below and we'll try and answer them either in the comment section or with a future video.